Good afternoon. My name is Frank Rhame. I'm an infectious diseases physician at Abbott Northwestern Hospital and the University of Minnesota in Minneapolis. I'm afraid I have to welcome myself to Uganda. I can't be there in person. I'm only there virtually. My loss. I've been there now 11 times. This would have been the 12th, and I've enjoyed it very much. So you'll see my starting image there. I always try to put something in there that reminds me of the place at which I'm speaking. The little image down there on the right side, just below the JCRC logo, is the climate map of Uganda. And one of the things I've always enjoyed most about Uganda is your absolutely wonderful climate. Everything blue there is tropical. The climate is great. It never changes. So Uganda is the place where the climate never changes and the leader never changes. So, all right. So I'm going to start with a grim image. This is the cases of Uganda until about 2 weeks before this is being broadcast. Make no mistake, Uganda is going to have a big problem with COVID. The only countries that have avoided having a huge problem with COVID, a life-changing problem with COVID, have been New Zealand, China, which did it through draconian measures, a little bit maybe Iceland, and Taiwan. Everybody else has had big trouble with it. It'll come, mark my words. And I just want to point out before I get into this that there's no question of where this virus came from. It is a bat virus. It is very much like one of many bat coronaviruses. This is a species jump. Nobody made this thing up. It was a species jump, and nature has dealt us a very difficult hand to play here with this one. Probably more deaths are going to come from this pathogen than anything since the outbreak of influenza in 1918, 1919. So the Simply Speaking deck actually has some images on COVID. Unfortunately, as you can see from the date there, 25 March 20, it's quite old. So I'm really not going to use more than a few of the images from that. There's nothing wrong with those images. They're just way out of date now. So this is the outline. I'm going to talk about what impact HIV has on the course of COVID. I'm going to talk about the clinical presentation of COVID, the therapy of COVID-19, the formal name of it, Provisional Transmission. I'm going to do a scientific interlude. Those of you who see me speak before know I usually impose a bit of science on you just for the aesthetic value of it. And I'm going to talk about vaccine because we're doing one of the big vaccine trials, the Janssen trial called Ensemble. So here's the first one, impact of COVID on HIV. So I'm going to start with a wonderfully large cohort that was put forth in the Western Cape. They have over 3.5 million people, almost 3.5 million people under observation in the public hospitals there. And of them, 22,000 were COVID positive. They looked at the standard mortality ratio adjusted for age, sex, and comorbidities, unfortunately not for overall health predictors. So that it's not a perfect adjustment. And they looked at what was associated with mortality. And it turns out a rather typical set of predisposing factors. You can see that men in the top two there, men are a little more likely to have mortality than women. Age is absolutely the hugest impact on mortality. All of those things in this forest plot there go to age. The bottom one, over the farthest to the right, is people being over 70. And the hashtags there are at 2, 5, and 40. So you're almost a 20-fold increased chance of death if you're over 70 from this disease. Diabetes, the next 4 are big factors as well. Non-infectious comorbidities also matter. Hypertension, a bit. Obesity, a bit. And TB actually made the mortality go up. And on this reckoning, the mortality was about twice as high in the HIV positive people. Now, unfortunately, I think this is not perfectly adjusted, so this isn't the perfect cohort, but it's a nice starting place to look at this issue of what are the predisposing problems in COVID. Another study is the Veterans Administration Aging Cohort Study. They have a very large number of HIV positive veterans. They've matched them 1 to 2 with HIV negative veterans. And in this analysis, they looked at adjusting by age, sex, race, BMI, alcohol use, and smoking. And they examined the incidence and outcome of COVID-19 infection. And the outcome was that people living with HIV had higher COVID testing rates, but very similar incidence and outcome in this. Here's their data. You can look at that a little bit. And this was a very large study, almost 30,000 people that were HIV positive, and of course twice as many people that were HIV negative that were matched. This is very well matched cohorts, and I think this is probably as good an indicator as anything in the studies. So there's another study which I think had some interesting observations. This was a study where people voluntarily reported cases to this registry, and they looked at the outcomes. Now that's a problem because you don't know how people decided whether to register them or not. But from the early part of the outbreak, they had 286 people who were entered. Most of these are people living with HIV. They had 89% were undetectable, almost half had hypertension, a third were obese, and 20% had diabetes. And they looked at a multivariate analysis. Now this is not comparing people who are HIV positive with people who are HIV negative. It's an examination of the risk factors within the group that are HIV positive. And what they saw was a three-part separation, whether you looked at hospitalization or mortality, and the green ones are people with CD4 count over 500, then the red ones are people between 2 and 500, and the blue ones are people with CD4 counts less than 200. And there was a significant difference. You did better if you had a CD4 count over 500. That surprised me a little bit. I would have thought that the breakpoint was at 200, but the people above 500 did better than the people between 200 and 500. So I'm going to skip those. So let me start with the incubation period of COVID. There's a plot there of the incubation period, and what it says is that there is a broad range of incubation periods, maybe 2 up to 14 days, but the vast majority of people had disease within 10 days of exposure, and the most of the people were around 5 days. So 5 days make it 4 to 6, pretty good estimate of the incubation period. And what are the initial symptoms? So this image shows from top to bottom, headache, runny nose. Runny nose is perhaps a little bit less common in COVID than it is in other viral respiratory infections. But the odd thing is this loss of taste or smell, which is about almost half of the people. It goes away about half the time it doesn't go away. Then this typical stuff of respiratory viral infections, sore throat, cough, fatigue, more systemic symptoms with this than with any other viral respiratory tract infection, except perhaps for influenza. Biggest difference between influenza and COVID clinically is the tempo. People with influenza, classic influenza, they go from well to very sick in half a day. The onset of COVID is quite a bit more insidious. In fact, many times people don't really realize they're sick until a day or two that they've been into it, and then they sort of recognize in retrospect. That's a key to the transmission, which we'll get into in a second. People don't really figure out that they're transmissible until even after their onset of symptoms. And this virus spreads very well before the onset of symptoms. That's one of its very sneaky capabilities. Diarrhea is common as well, and overall body aches, very common. There are many extrapulmonary manifestations of COVID, and that is another distinguishing feature. I'm not going to list them all, but one of the problems we have, particularly with respect to the brain manifestations and the heart manifestations, is how long they're going to last. So it does look like some people wind up with lasting damage of their hearts and lungs, and sometimes maybe of their intellectual capabilities as well. So a clinical point that distinguishes COVID from most other illnesses is this business of ground glass opacities. So what you see there is 3 cartoons of alveoli, and the left one is normal alveolus. And then as fluid starts to get into the alveolus, it does not actually obscure the underlying architecture of the lungs. And that's what makes ground glass opacities different from infiltrates, because the underlying architecture can be seen. There's just a haze over it. And then when it gets full of, when the alveoli get full of debris, then it becomes an infiltrate. Here's a picture of it. In the top two, A and B there, are the ground glass opacities, just a little patch of haziness. They tend to be peripheral. And then as things advance, they have a stage they call crazy paving. And then when it gets severe, in the last two of the 6 images, it is outright consolidation. Now I'm going to talk about the treatment. The treatment is, I'll begin with a little bit of a perspective. One nice thing about having old guys around is they have some perspective. This is the very first program from the very first AIDS conference in 1985, 35 years ago. And I put this up here. I actually have it. It's a fun artifact. If you look at in this program, the compounds that are used in treating humans are listed here. These are all the treatments that have been used, reported in that first international conference. Not one of them turned out to have any effectiveness. So this is 4 years after we first discovered AIDS, and everything that anyone thought was worth studying didn't work. So don't be surprised if it takes us a while to find some really effective therapies against COVID. So I'll just go through briefly the medical management as WHO and the NIH have suggested it. And rather than, this deck has got actually about 1/3 hidden slides. So the deck is going to be available to you. I'm not going to go over it just because I don't have quite enough time, but there are differences in the way you manage mild disease. You typically don't do a lot of treatment other than support for mild disease. When people get moderate disease, then they generally need to be under observation in a hospital. When they get severe disease, they're in ICUs, and when they have critical illness, it becomes a matter of really very sophisticated ICU management. So this is just a quick cartoon of the transitions that happen in the course of disease if it gets severe. It starts out on the left with mild disease, where most of the impact is from the virus itself causing trouble. And then as it switches over toward the right, it becomes our reaction to the virus which causes the trouble. So at the left are the places where you want to use the direct antivirals. If we get them, remdesivir, convalescent plasma. You don't want to do it if they aren't a little bit sick, because there are a lot of people who are a little sick who don't go very far. But if they get a little more sick, then you use those. On the right, you want to do the things that combat the immune response. So that's when corticosteroids and some of the inhibitors of immune response are likely to have their best benefit. Corticosteroids for sure. The various other immune modulators haven't worked so far. I'll finish this little segment on the question of antibacterials. We wind up using antibacterials a lot more in the care of COVID patients than people actually have bacterial infections. Problem is, you got somebody who's getting very sick in front of your eyes, and they've got a chest foot infiltrate. It's really hard to not treat them. The vast majority of them probably don't have a bacterial infection, but 3/4 of them wind up getting antibacterials. I don't know how to avoid that. You just feel like you can't not give them treatment for community-acquired pneumonia when you see all that infiltrate and people having respiratory failure. Okay, prevention of transmission. So I need to start the transmission prevention issue off with this concept of R0, as the Brits call it, R0 as the Americans call it. That is the number of transmissions that on average a person produces in a totally susceptible population. So that actually is a moving figure, because as we get people infected, not everybody will be infected, and our interventions can change R0 considerably. And in fact, that's really the way we should think about what we have to do to prevent transmission of COVID. Every prevented infection is a victory. Every transmission that occurs is a defeat, and it's really a grinded out war of attrition between us and that virus. And we need very much to encourage people to do the things they need to do, which can range from stuff which isn't that hard, like distancing and wearing a mask, to shutting down, which is very disruptive. on the economy. But the better you are at the easy things, the less likely you are to have to do the hard things. So R0 changes according to the outcome. Now this is a little graph here of a couple of illnesses as a function of what fraction of the transmissions come from asymptomatic people. That's over to the right, you see HIV, and the R0, which is the number of transmissions per person, which is the left-hand axis, the vertical axis. And you can see that HIV doesn't get very many transmissions per person, but most of the transmissions come from asymptomatic people. Influenza is right in the middle. Things like SARS is over toward the left. So lots of so one thing that turns out to be responsible for why a lot of the transmissions occur early, even before symptoms, is depicted here. This is the concentration or the amount of PCR positivity. We measure that by the number of cycles it takes to detect the presence of the virus. Lots of cycles means there's not very much virus there. Few cycles means that it was easy to detect the virus after just a couple of cycles, meaning there was a lot of virus there to begin with. So high on this graph, the upper thing is the cycle values. So you see that when it's low, which is at the top of that axis on the left, there's lots of virus. So as you look at the course of the amount of virus over time, you see that people had higher values very early. So the routes of transmission of SARS-2 boil down to touch, large droplets, which are the things that go